So our next speaker is Dr. Anna R. Quinones from Oregon Health and Science University. Dr. Quinones is an associate professor in the Department of Family Medicine at Oregon Health and Science University. She is a gerontologist trained in health services organization and policy from the University of Michigan's School of Public Health. Her research interests address racial and ethnic differences in age-related changes, coexisting chronic disease, and healthcare delivery changes designed to improve the management of chronic conditions for vulnerable older adults. Her work aims to understand disparities in health stemming from differential access to resources for disadvantaged populations and consequences for health and well-being in mid and late life. Currently, her work focuses on the development of and intersection between multimorbidity, disability, cognitive function, and the role that specific multimorbidity combinations play in accelerating adverse health outcomes among racially and ethnically diverse groups of older adults. Dr. Quinones, we welcome you. The floor is yours. We look forward to your presentation.
Thank you so much. Can you hear me and
Yes.
see my slides? Great. Wonderful. I'd forgotten that I'd provided such a long introduction, so I apologize for having to read all of that through, but it did save me a little bit of time. So as mentioned, I am sitting over here across the country in Portland, Oregon at Oregon Health and Sciences University, and happy to join you this morning or this afternoon, depending on where you are, to talk to you about our recent work on these longitudinal interrelationships between multimorbidity function and cognition and the disparities that we observe by race and ethnicity. So as mentioned, I'm a gerontologist and focus quite a bit of my research effort on understanding different patterns of multimorbidity and associations with cognitive impairment and other health outcomes among diverse groups of older adults. Getting some of the housekeeping out of the way, I have no financial conflicts of interest to disclose. Funding sources from the NIA. The views here that are expressed are my own and my team's own and don't represent the official views of the NIH. I thought I would start off by talking quite a bit. So we've heard quite a bit this morning from Dr. Robinson-Lane and Dr. Langa and others around these associations of multimorbidity or multi-comorbidity or multiple chronic conditions. So wanted to set the stage a little bit around what we know about people who have 2 or more coexisting chronic diseases or multimorbidity. A lot of literature out there being put out there at an increasing rate that documents these cascading consequences of having 2 or more chronic conditions that are really greater than the risks that are attributable to having any of the single constituent diseases. So something about having the combination of particular chronic diseases that affects individuals more so than having any of these diseases singly. And a lot of work out there as well documenting the prevalence of multimorbidity, its associations with disability, and the costs to the healthcare system. So graphically, just about 2/3 of the US population aged 50 and older have multimorbidity. And when we look at that further by age strata, we see that about half of early middle-aged adults 50 to 65 have multimorbidity, and those risks increase exponentially with aging. So just about the Medicare, the just recently Medicare eligible set of older adults 65 to 74, again, about 2/3 approximately. And then once we get to older adults that are 75 years or older, a whopping 82% of older adults have multiple chronic conditions. So this extends to older adults with dementia multimorbidity. So people with dementia have among the highest levels of multimorbidity of any long-term chronic condition. Dementia multimorbidity is associated with poor health outcomes, just as we see with other forms or other combinations of multimorbidity. Also predicts poor outcomes, poor quality of care response. And the real challenge here to the 21st century is how to provide good quality care for older people with dementia. And this is really exemplified by people with dementia multimorbidity. So preventing chronic disease might be an important strategy to avert or delay cognitive impairment. And the way that we think about this in the field, dementia really is that disorder that draws attention to all the complex challenges of multimorbidity and the implications of not addressing them systematically. So it really is a challenge to the healthcare system and to individual families alike. So I wanted to also set the stage and just be pretty aware and disclosing that the field really is in a bit of a moment right now. It's in a bit of flux on how to measure and how to operationalize and how to think about multimorbidity. So this was a piece recently published by some colleagues that stemmed from a 2018 multimorbidity workshop and summit at the NIH. So essentially for all of us here within our own research endeavors, the recommendations, the best recommended practice here is just to be transparent and report how we measure either comorbidity in our studies if we're indexing on dementia, or multimorbidity if we're just considering the confluence and the prevalence of multiple chronic conditions. Be very transparent about that, be very upfront about how we are measuring it, how we're constructing that measure, and as well as the assumptions and the rationale used. So at the moment, the measurement issues are partially dependent, not only on what data sources are available, but which chronic diseases are measured within those data sources. How can we ascertain those chronic diseases well within those data sources? So just worth mentioning, with EHR data, we have great frequency and intensity of data. It might be high, specificity and detail is often high, but the data quality is very mixed. And there can be some significant issues related to completeness and accuracy. With longitudinal survey data sources, we have great frequency and specificity is quite fixed, as with the health and retirement study that Dr. Lange just showed us about. But there may be some limitations with regard to the breadth of what's available. And then claims data, administrative data sources are often somewhere in between that. And of course, you can't generate a claim if you're not insured. So there are certainly some missingness inherent in those data with regard to who are generating claims. So the tension here I just want to point out too is really balancing that tailoring of the measurement for the purpose of the objective of our own studies, but also balancing against comparability and standardization so that we can say something across our studies. We can learn across all of our studies. So one of the guiding lights and one of the organizing frameworks that we often rely on, at least here in US-based studies, is this publication that stemmed out of a subject matter, an expert process on subject matter, deliberative process coming out of the Office of the Secretary of Health and Human Services, OASH, the Office of the Secretary of Health and Human Services. They convened a multiple chronic condition working group across clinical medicine, epidemiologists, public health experts, and developed a list that would include conditions that meet the definition for chronicity that are prevalent among older adult populations that are potentially also are amenable to public health or clinical interventions. And essentially this list contains 20 chronic conditions, including Alzheimer's disease and other senile dementias. Wanted to call that to your attention and then really just get to the nitty-gritty of the talk here. I wanted to go through several of the studies that we've done on our team and how we've approached this area of research, and specifically call out the associations with cognitive impairment and dementia in our own work. So first I'll talk about a study that we did using the National Health and Aging Trend Study, collected just right up the corridor from Duke University up in Baltimore at Johns Hopkins. It's an annual nationally representative community sample of Medicare beneficiaries, 65 and older, includes oldest of the old, but is that true longitudinal repeated observations of individuals upon study entry. And to date, I believe the 2020 survey is out and about 12,000 or so people are surveyed in the NHATS data. So I wanted to talk about a paper which we did, an analysis which we did where we sought to track the associations between multimorbidity combinations and functional limitations operationalized as ADL and IADL function. So here we first identified all of the unique multimorbidity combinations in these data sources, in the NHATS data source across a year, and then looked forward to associations with ADL, IADL. We found 573 unique multimorbidity combinations, quite a few, with some really great distribution. So not a lot of people have the exact identical combination, but there really was quite a spread between individuals with regard to their multimorbidity patterns. So what we did then is we aggregated all 573 into 4 mutually exclusive categories, multimorbidity categories, which we defined as somatic conditions only, so only those physical health conditions such as hypertension and diabetes, multimorbidity combinations that included cognitive impairment without depression, so cognitive impairment plus another physical or somatic condition. The third group was multimorbidity combinations that included depression or depressive symptoms without cognitive impairment. And then finally, a fourth group that included both cognitive impairment and depressive symptoms. So here is a figure, descriptive figure. It's really a histogram, but it's just oriented the opposite way you normally would across that y-axis vertically. So that y-axis displays each of those 573 unique combinations, and the color coding are those 4 mutually exclusive combination groups. So there's the somatic, the cognitive impairment without depression, depressive symptoms without cognitive impairment, and the combination that represents both. And what we found here is on the y-axis, you see displays the mean disability levels or mean functional limitation levels along ADL and IADL domains, with higher counts representing greater functional limitation. And we see that the mean disability levels associated with the multimorbidity combinations containing both cognitive impairment and depressive symptoms is much higher than the other 3 multimorbidity groups, perhaps not surprisingly. So we also saw these associations bear out in our negative binomial regression models, where we did indeed find that older adults with disease profiles that included both mental health and cognitive deficits had greatest levels of functional limitations. So next I want to talk to you about just a couple of studies, just 2 studies where we looked at the health and retirement study data, and where we found and documented longitudinal changes, so growth curve trajectory changes in chronic disease accumulation and multimorbidity development, differences by racial and ethnic groups in that HRS data. We looked at the HRS data across 16 years, I believe 1998 through the 2014 wave. And what we found is that Black Americans started off with a higher initial level of chronic disease burdens, that higher intercept compared with their non-Hispanic white and Hispanic or Latino peers. And they crossed that multimorbidity threshold on average about 4 years earlier than non-Hispanic white populations, non-Hispanic white groups in our study sample. So we also show in the paper that while Latinos had a comparable or just not statistically significant intercept, so the comparable initial level of chronic disease, they accumulated chronic disease at a faster rate over time. So that slope, that's why you see that those two trajectory lines between non-Latino whites and Latinos converging by the end of the study period. So I wanted to briefly, in about 10 minutes, please I can, maybe 15, talk about work on joint multidimensional trajectories using the HRS data that we currently have under review. So again, we examined the HRS 1998 through 2016 waves. We examined respondents aged 65 and older. And here we employed group-based trajectory models to identify clusters or latent classes of older adults following similar joint trajectories across 4 different health domains. So again, we looked at that chronic disease accumulation, multimorbidity development. We also examined trajectories of instrumental and daily activities of living, cognitive performance, and depressive symptoms. And with regard to multimorbidity, we defined that, or with chronic disease, we examined somatic chronic conditions in the HRS, so heart disease, hypertension, stroke, diabetes, arthritis, lung disease, and cancer. And as I mentioned, functional status, we used an index of ADL and IADL combined. Cognitive function, we used the 27-point cognitive scale. And with regard to depressive symptomatology, we employed the HRS's 8-item CESD, or the Centers for Epidemiological Research and Depression scale. And as I also mentioned, we used group-based trajectory modeling and a recent generalization or application of group-based trajectory modeling to examine multiple outcomes, multiple trajectories over time across these 4 different health domains. And then, sorry, once we identified the multidimensional trajectories, once we identified the groups of respondents that followed similar multidimensional trajectories, we also conducted multinomial logistic regressions to examine the associations of baseline sociodemographic and health-related factors with that assigned trajectory group membership. So what did we find? We settled on a 4-group model with these distinct joint trajectories of chronic disease accumulation, functional status, cognitive function, and depressive symptoms displayed in this figure. So each of those columns, those 4 columns across the 4 domains, which are displayed by row, those 4 columns represent each of those 4 identified multidimensional trajectories. So we named these 4 distinct trajectory patterns. That first group we examined and determined this really looks like a minimal impairment with very low multimorbidity group. It represented about 33% of the sample. And really, we observed very limited deterioration across the age span. Then with regard to that second group, we named this group minimal impairment with high multimorbidity. And this is an interesting group because across the age span that we examined, 65 to about age 90, we saw really limited deterioration across most of these health domains except for chronic disease burden. So that multimorbidity level was already quite high at age 65 and increased over that age span. But despite having this high level of multimorbidity, individuals along this class really did exhibit very low deterioration across ADL, IDL, cognition, and CESD, depressive symptom scales. Then the third and the fourth group, those final 2 columns really displayed the highest level of deterioration over age. This third group we called multi-domain impairment with intermediate levels of multimorbidity. And really what characterizes this class is that worsening cognitive performance across the age span, starting lower and really declining across that age span. And then finally, the fourth group, quite impaired again across multiple domains and having very, very high chronic disease burden, high multimorbidity levels. So again, this group had worsening cognitive performance, substantial functional limitation, and higher depressive symptomatology. So while we see these distinct classes of older adults and they have varying levels of experiences with high or intermediate or even low multimorbidity levels, there seems to be really two very divergent pathways that can be characterized by either resilience to these high chronic disease burdens, as we see in group 2, or as we see in group 3 and 4, very substantial impairment throughout old age in relation to those high burdens. And as I mentioned, we used these indicators for probability of membership in each of these groups or these classes, these identified latent classes. And we conducted some multinomial logistic regression analyses to determine predictors of class membership. Here, I'm just displaying race, ethnicity, and BMI category as the highest odds ratios that we observed in our analyses. So we see that, well, first of all, I should mention we included other predictors here in our multinomial regression, where we examined not just race and ethnicity, those indicators, those mutually exclusive indicators, but we also examined female sex, educational attainment, nativity status, so foreign born or US born, household wealth quartiles, baseline coupled status of either living with a partner or being married, baseline smoking status, and as I mentioned, also BMI category. But what we found was that Black respondents had greater odds of being in either of the two multi-domain impairment groups, 3 and 4, those worst performing groups. Similarly, Latino respondents were more likely than white respondents of being in either of those two multi-domain impairment groups. And then of all the characteristics that we included in that adjusted model, obesity also had a very strong association with membership in either of the two multi-domain impairment groups, but particularly with regard to group 4, that multi-domain impairment with very high levels of multimorbidity. So what can we conclude from this? So our study reflected like I mentioned before, those varying courses of chronic disease burden and impairment across multiple domains that are important in aging, important in geriatrics and gerontology. Those older adults that had a high probability of membership in the minimal impairment with low multimorbidity group were consistent with a healthy aging trajectory along those multiple domains of well-being. Respondents in this group had high levels of function across multiple domains in late life. Also, as I mentioned, we were particularly intrigued with that second group, the older adults with minimal impairment and high multimorbidity. They fared fairly well on other domains of well-being as they aged, despite experiencing high multimorbidity burden. So it seemed more like a resilience to those high chronic disease levels. With regard to the predictors that we examined in those multinomial logistic regression analyses, Black and Hispanic race, ethnicity, lower wealth, lower education, male sex, and smoking history were all significantly associated with membership in the two multi-domain impairment classes. So what we concluded is that there's substantial heterogeneity in these combined trajectories of these interrelated health domains in late life, and membership in the two most impaired classes was much more likely for minoritized and vulnerable older adults. So really briefly, in the few minutes that I have left, just wanted to provide a little bit of a summary of where we can go toward this next generation of multi-level effective disparities health equity research. We heard quite a bit about this already in the talks delivered earlier today, but it bears repeating. So our next steps really are to understand how best to support vulnerable older adults with complex care needs. So really thinking about those co-occurring diseases, those personal, those social conditions, not just the individual level, but also what surrounds individuals, older adults, and patients. And then thinking about interventions, kind of these next steps of what do we do about this, investments that we need for those more disproportionately affected population groups. So really that implementation work that's needed for intervention development, to identify what works for whom and under which circumstances they work best. So we really need to continue to refine, to advance, to evaluate care coordination, medical home models. Are these the way to deploy care for patients with multiple chronic conditions, potentially chronic conditions across multiple systems that involve multiple providers, different specialists, their geriatricians if they have them, primary care practitioners. But ultimately that need to continue to shift our focus away from treating chronic diseases singly, from that acute response, reactive response, to more of a proactive chronic disease management in our approach to clinical care. So really, what does this 21st century health or healthcare delivery look like for adults with multimorbidity? So these really that integrative, multidisciplinary way of valuing both generalist as well as specialist skills. And really, we should be thinking about older adults with very complex care needs, older adults with dementia, multimorbidity as being a great litmus test for how to really deploy care that's responsive, that's effective, because these really are the most complex patients with multiple chronic conditions and multiple sets of issues that we need to address. That is all for me. And I tried to keep us mostly on time, but wanted to acknowledge my colleagues and thank you for inviting me and thank you for your attention.
Okay. Okay, I just gotta get my speakers and microphones all lined up. That was very, very informative. I want to thank you for that presentation. I'm looking right now, there's no open questions, but I just had one question before I sort of give other people the opportunity to jump in. I had done some analyses on mortality data. It was the multiple cause of death mortality statistics. I published this paper in 2002, and I looked at over the top 15 causes of death. I looked at the number of causes that were reported using the multiple cause field on death certificates, and it turned out, with the exception of primarily cancer, that the number of causes reported on the death certificate was just a little bit above 2. And so when in the presentation on talking about multimorbidity, it seems to me that the ability of humans to survive a whole broad range of diseases seems pretty good if it's one condition that has to be held under control, but there's got to be some explanation as to why across so many different disease conditions, the 2 of the top 15 is about the average number of reported causes. And I understand that there can be causes that don't contribute to death. But when you look at causes that do contribute to death, the average over several decades in the United States is above 2. And I'm just wondering if you had any thoughts about that when you're looking at multimorbidity in combination with Alzheimer's, or more generally with respect to dementia, thinking about how that process eventually leads to mortality, just because the body fails and the medical treatments don't work.
Yeah, that's a great question. And I do have a lot of thoughts about this question. And in particular, so the paper that I showed earlier that came out of the multimorbidity workshop in 2018, lead authored by Jerry Soules, there we really talk about, finding that right instrument for the purpose. And I've been thinking about this quite a bit. So the way that we think about multimorbidity, the way that the field currently analyzes and examines different combinations and how different combinations may be associated with particular outcomes, such as mortality, such as disability, such as other geriatric syndromes that are not death, such as cost to the healthcare system, there may be really different and important contributors to each of these outcomes that we need to think about in terms of perhaps kind of a one size does not fit all. And again, being very upfront and open about what the purpose is of that study. Are you interested in examining associations with mortality and thinking about which of those chronic disease combinations are much more fatal or much more associated with that proximity or that proximal outcome of death, which may be very different than conditions that are more disabling, that affect your mobility, or conditions that affect your cognition. So yeah, I think it's an open question. I think it's a very good question. And I think it's a way that we can evolve the field in continuing to examine and explore these specific associations with particular outcomes that are different and that are important to the healthcare system and to families.
Okay, thanks for that. 2 questions popped up very quickly. Well, sort of chat comments, I think they are. No, they're in the questions. Death certificates follow an algorithm, and the doctor filling out may never have met the deceased person. That's certainly is true. And the diagnoses listed on the certificates are notoriously underreported. It sort of depends on, you can go through cause. There's a huge literature on validation of death certificate reporting. But whatever,
there may be limitations to the number of causes that you can list on a death certificate. So there are lots of known limitations. As I mentioned before, the different sources of data tell us different things and have different constraints and different strengths as well.
Yeah, but it's still notable that the average number of causes among the top 15 is 2. And yeah, it's not 1. It's not close to 1. It's 2. And it's very close to 2. And so, it's a reporting process, and all data collection methods have their weaknesses, but I thought it was relevant to the multimorbidity. We